next talk is Immediate versus Delayed Surgical Management of Infant Cryptorchidism with Inguinal Hernia, presented by Dr. Walter Ramsey.
Thank you very much for the opportunity. Cryptorchidism, or undescended testis, affects about 1 to 5% of full-term males and up to 45% of those born prematurely. It's commonly treated with orchiopexy at 6 to 12 months of age, which allows time for the undescended testicle to oftentimes spontaneously descend. Inguinal hernia, on the other hand, affects about 1 to 4% of children and occurs in up to 30% of those born prematurely. But the timeline for operative repair is much more variable, although it's often treated before discharge from the NICU in patients born and detected postnatally. The co-occurrence of undescended testis and inguinal hernia is estimated to occur in about 1 to 3% of baby boys, but this is likely higher in those born prematurely. However, rather than delaying surgery until 6 to 12 months of age, as in isolated cases of undescended testis, many surgeons elect to perform orchiopexy and inguinal hernia repair immediately upon diagnosis, rather than delaying surgery. When undescended testis and inguinal hernia occur simultaneously, there's no recognized guideline or consensus recommendation that establishes the ideal timing for surgical intervention, and this may have implications in patient outcomes. We hypothesized that early surgical intervention provided no benefit for newborns born with both undescended testis and inguinal hernia. To analyze this, we reviewed 5 years of nationwide readmissions database data for newborns with a diagnosis of both undescended testis and inguinal hernia, looking at the operative management, comparing those who received surgery for inguinal hernia repair on their index hospital admission versus the deferral group who did not get inguinal hernia repair prior to discharge. We analyzed readmission rates as well as complications, including orchiectomy, rates of bowel ischemia and incarceration, testicular atrophy, and surgical infections. We examined over 1,300 patients. You can see here the features of those patients that about 2/3 of them were premature, and most were treated in large and metropolitan teaching hospitals. The repair of the inguinal hernia was performed during index hospital stay in about 30% of them, and the remainder were deferred. This chart illustrates the characteristics and outcomes of patients who underwent inguinal hernia repair during the index hospitalization versus who underwent deferral of surgery. And there's no, you can see the earlier repair group had a higher proportion of premature babies and was associated with longer hospital length of stay and greater costs. However, that group also had higher rates of orchiectomy, although there's no difference in the rates of testicular atrophy. A few other complications, notably that were higher in the early repair group, include pneumonia and sepsis. Looking just at the 832 baby boys that were preterm, earlier repair was associated with longer hospital length of stay and with higher rates of genital edema, but there were equivalent rates of bowel resection. There were no orchiectomies in this group and no documented cases of testicular atrophy. We should address some of the limitations of this study that are due to our use of a national database. It lacks some granular information that could be useful, including gestational age, occurrence of some events like postoperative apnea, and physical exam findings such as whether or not the undescended testis was palpable, laterality, et cetera. And you can't assess more specific details on the surgical time due to inconsistencies in the database, like a timestamp of when the surgery was performed on that index admission. Outpatient data isn't captured in this data set. However, if a patient had a complication that required readmission, and that would be captured in nationwide readmissions database. And finally, this chicken versus egg phenomenon, we don't know the temporal relationship between the measured outcomes and the surgical management strategy. So it's entirely possible that patients with longer length of stay underwent repair while in hospital based on convenience rather than early repair producing the longer hospital stays. But in summary, we looked at 1,300 newborns with both undescended testis and inguinal hernia and found that early repair was not associated with better outcomes, that deferral had comparable rates of bowel resection and hospital readmission, but was associated with lower rates of orchiectomy, and this was consistent among those born prematurely. Deferral of inguinal hernia repair in newborns with both UDT and inguinal hernia appears safe and effective. However, acknowledging the limitations of our study, we propose that prospective studies should evaluate the optimal timing, while we, in the meantime, recommend waiting 6 to 12 months of age until operating to allow time for possible testicular descent. Thank you.
Agostino Piero, Toronto. Thank you very much. Very interesting study. I would like to say that one of the advantages of laparoscopy is that you could actually not interfere in the groin and repair the hernia and subsequently do the orchidopexy. Now, I just wonder if in your review, you've been able to differentiate how many hernias have been done open or laparoscopic.
Thank you for your question. That's a huge limitation, I think, is that you can't distinguish the operative technique, whether these were laparoscopic or open. And it's just a limitation of the data set. And I think that would have to be one of the things taken into consideration if this was evaluated prospectively, was the operative approach.
Thank you.
Then another question I had, a lot of people will wait until a certain post-gestational age to repair inguinal hernia. Mm-hmm. So were you able to capture how many of those that were deferred really did get an early repair, but a little bit later than the index admission versus, who really was deferred until 6 to 12 months?
Thank you again. The gestational age isn't something that we could correct for because it's not available in nationwide readmissions database. It would definitely, again, be something we'd have to look at in a future evaluation. And I understand it's arbitrary that we said the first hospital admission was when we defined early versus late, and there can be some variability in time based on how long that admission is and other factors.
Thank you. Thank you.
Thank you.
Thank you.